Good evening to all of you. It's again a great privilege to have all of you to a great calcium, another series of great calcium masterclass. Yeah, as you know, Calcium Masterclass has been a great forum which had been cared and curated basically for all of you, because as we move to the world of treating some of those complex cases in treating patients, I think forum of this nature basically serves as a on a bowl or a platform where you can discuss about various techniques and various thoughts on managing complex cases of calcium and various cases aspects with the field of intervention cardiology. Let me assure you that every month or twice when we connect and come on this platform of Calcium Masterclass, it forms a vista of opportunities for many top intervention cardiologists coming together from India and overseas, sharing one of their best of their cases, creating a great amount of pearl of wisdom for all peers who are learning from this forum. My name is Ehsan Raza. I work as a general manager, marketing and commercial effectiveness at Translumina. I am very happy to talk to you and give you a sneak peek view of what does Translumina stand for before we hand over to the moderator of the evening to take this program forward. As you know, we are a very humble company with a humble beginning in 2010. Today, we are proud to be one of those companies which have the footprints in more than 80 countries. We created a great strategic partnership to see that how do we bring innovation to make it much more accessible. And this is all powered with great manufacturing facility in India and Germany, with our collaborations and with a paragon of learning center at Germany, German Heart Center. And let me happy to share with you that most of our products are C certified. And perhaps we are the only company in the world today to have data on polymer and a polymer free technology stents, which makes to help your patients to see that we have a great outcome. Not only that, our forays continues. We will continue to bring a lot of disruptive therapies in the field of boosting catheters, mitral valve replacement, and aortic valve replacements in times to come. And finally, coming to introduce the speaker of the evening today, I'm very privileged and honored to have Dr. YVC Reddy sir, who is a consultant and a great intervention cardiology from Apollo Hospital, Chennai. And he is one of those who has contributed immensely to the field of intervention cardiology to see, and has contributed a lot of data, a lot of papers and publications to see that how you will strengthen the field of intervention cardiology. Sir, over to you to take this learning of calcium masterclass forward and introduce and facilitate that entire evening today, sir. Over to you, sir.
Good evening, Ehsan. Thank you very much for the nice introduction. And it's a very great evening. I feel very happy to be and also proud to be moderating this wonderful session. Calcium, we all know as interventional cardiologists, has always been the bugging thing. All of us would have landed up in some challenge or other when we deal with calcium. And of course, the last 1 decade has given us tremendous advances. And now, of course, that fear is not there. In fact, when I used to teach the youngsters, the first thing we tell them is calcium is a trap. Sometimes you just cross and then the balloon will cross and then you are already committed and then you are not able to crack it and then the mess comes. Or if you crack the lesion as well, you think you have cracked it and they put a stent and you can't expand it. You are not prepared the bed. So there are a lot of traps and challenges in this calcium issues. And the calcium, of course, I am sure we are going to see wonderful case presentations and discussions. But before we start the session, let me welcome the chairpersons of the day, Simon Wilson. Impeccable background of a lot of interventions, including good experience with IVL, the greatest advance that has happened over the last decade in calcium therapies. And my friend Anantaraman is here as well, chairing the session, and to co-chair. And of course, we have a host of luminaries in interventional cardiology in the country presenting their experiences in the form of case presentations. Without much ado, I think first let me welcome Simon Wilson, who is a consultant in interventional cardiology at St. George's Hospital, London, with a subspecialist interest in diagnosis and management of angina and CAD, over 2,500 interventional procedures, including CTOs, and of course, IVL and calcium is what we're going to listen to you, Simon. Welcome, Simon Wilson.
Thanks so much for the introduction. As I said, it's an honor to be here. I totally agree with you. Calcium is our biggest challenge in coronary intervention. I would much rather have a 1-1-1 bifurcation with soft plaque than a heavily calcified lesion, because I think you're more predictable. Well, maybe we've got IVL now. Our chances are better.
Yes.
But yeah, it is a major challenge and should never be underestimated. I totally agree with you. So I'm going to share my screen with you. And as I go along, if there's any questions or things we'd like to expand upon, I'd like to just stop and do that as we go. So feel free to interrupt. I'll share my screen now. Okay, so we've got lots of great talks lined up this afternoon. I'm going to kick off with talking about the mechanism of action of IVL and how it is different from our existing technologies that we had before and how that might translate to better outcomes in certain patients. I'm going to start with this, though. Did we actually need to develop IVL? Well, before we had IVL, we had balloon-based techniques and atherectomy devices that we used to disrupt calcium. And of course, these had some advantages and we used them. But the reality is, if you look at data before IVL, so all the pre-IVL era data, then consistently it showed that outcomes in patients with moderate to severe calcium were significantly worse than patients with only mild or no calcium. And I'm sure we've seen this because calcium's a hot topic. You know, we've been talking about it quite a lot the last couple of years. These slides have been shared a few times before. But the important thing is that it's not just a little difference, it's a big difference in outcomes. And it's not just TLR or, composite endpoint of MACE. We're talking about death as well, the hardest of all endpoints. And if we think about this, we have to be honest and say that some of these differences are down to factors that we cannot modify within the procedure itself. No matter how good we think we are as an operator, some of these are down to patient factors. For example, we know that more severe calcium is associated with advancing age, diabetes, CKD, multivessel disease, etc. And we can't realistically change that within the procedure itself. But some of these differences, there's no doubt about this, is down to the effects of calcium reducing vascular compliance, leading to suboptimal stent results frequently in many of our patients with the more severe calcium. And this concept is backed up by data where they perform landmark analysis, where they look at the first 360 to 720 days, and then they look at after that. I mean, here's one of these papers. It was from the 22 trials, and it showed that outcomes after 360 days, then those differences in MACE between patients with severe and not severe calcium were the same. Whereas before 360 days, you see the separation in curves. And that's telling us something. It's telling us it's something to do with the procedure. And it's because calcium reduces compliance, it makes it more difficult to deliver equipment, can damage the stent, damage the drug delivery system, and perhaps most importantly of all, promotes stent under expansion, which we know is one of the most powerful predictors of stent durability. So what's the problem with balloon-based techniques and atherectomy? Why do they fall short in terms of lesion preparation? Well, if we think about the three main morphologies of calcium that we have to deal with, there's concentric, there's thick eccentric, and there's large bulky nodular. And we think about these types of calcium with balloon-based therapies. I mean, the reality is that if you're going to develop a technology to disrupt calcium, it would be as far away from a balloon-based therapy as you could go. Because if you think about it, a balloon, what does it do? How does it affect the lesion? All it does is rely on push, hydrostatic force. That's all it does. It's not selective for calcium. It does not debulk. We know why we use them, because they just developed over time. That's what the first thing we used them, so we continue to use them. But the actual mechanism of action is very poorly suited to dealing with calcium. Now, in concentric calcium, it can be very difficult to apply enough force to affect sufficient lesion preparation. Sometimes you can get lucky and it'll do it. But even at high pressure, it can fail to achieve enough lesion preparation. And if you switch to an OPN balloon and go 35, 40, 45 atmospheres, I think there's a universal facial expression that translates across the globe when you're using an OPN balloon. And it's sort of like this, isn't it? You know, you go to 35, 40, 45, and you do that because the result is just unpredictable. You sometimes get it, but often it causes so much barotrauma that, of course, you've broken up the calcium, but you've led to a huge dissection. You maybe got a perforation. So it's not predictable. And I don't think we should be using equipment that's not predictable. And then if you think about the other two types, eccentric and nodular, this really exposes the limitations of the mechanism of action of balloon-based technologies. Of course, if you expand a balloon in eccentric or nodular, the balloon's going to expand away from the calcium. It's going to follow the path of least resistance. And what we know is that most luminal gain with balloon-based techniques is from overexpansion of the non-calcified quadrants. And of course, sometimes that's enough. You can be lucky and you get enough. You get a bit of stent asymmetry, but often it's not enough. And we know that the adventitia has a finite amount of stretch. And if you push it too much, you lead to problems. Now, atherectomy devices, they're totally different. They do have a major advantage. They debulk, okay, and that's unique to atherectomy devices, and they're selective for calcium. The problem we got with atherectomy devices is they're contact dependent. So, you know, they're very sensitive to wire bias, and they're going to struggle when you don't have the appropriate wire bias, even orbiter, and they're going to really struggle in larger lumens. And of course, they cannot modify deeper lying calcium. The other big disadvantage in my mind is embolization. You almost always get embolization, and you can see some subtle ECG changes if you're properly debulking. You won't see it if there's no sort of slowing down of the burr, but when you hear that slowing down of the burr, you always get some embolization. You always see some subtle ECG changes. Now, that's fine if you've got preserved LV function and you're doing a mid-right. But if you're doing a left main with poor LV function, is the patient going to tolerate it? Because it will come back, but it's a big consideration with people with poor LV, and you've got to do the left main, or you've got to do a proximal LED that's subtending a distal right. It's a definite disadvantage. Now, the other things, you know, common, it's a bit more tricky to use, bit of more of a learning curve. You have to use a dedicated wire. You got the problems with heat and rotational stress causing platelet activation. And then this issue about not being able to have a wire in to protect a side branch. I mean, I think that's over-egged often because it debulks. So I really don't find that it's uncommon to lose a side branch. You're not going to get plaque shift. The only occasion it's an issue is maybe in about 10% of patients where you get a much bigger sort of dissection than you were expecting, and it goes across the side branch. So it is a consideration, but it's perhaps not as big a consideration as other people have made out. So back to IVL. How does it differ? How can it plug these gaps that we have? Well, most of us know what the technology is. It's emitters within a specially designed balloon that when you activate it, produces a shockwave. Now, the shockwave then travels through the vascular wall, selectively disrupting calcium. And why is it selective? Well, a shockwave is just a high energy acoustic wave. And we know that energy or forces are only generated when the acoustic or shockwave travels from one tissue to a different tissue that has a high acoustic mismatch. Now, if you think about the internal elastic lamina, the extracellular matrix, the media, the adventitia, they all have basically the same acoustic impedance. So no force is generated. But as the shockwave goes from a soft tissue and then encounters calcium, there's a huge difference in acoustic impedance. There's an acoustic mismatch, and force is generated. So that is why it's selective for calcium. It's an advantage. What forces are generated? Well, there's three main types, and it's important to know about this. Certainly I like it because I like understanding the sort of mechanisms. It helps me appreciate why the technology is helpful. So there's compressive force. As the shockwave strikes the surface of the calcium, it generates compressive force that leads to fragmentation of the anterior surface. As it then travels through the calcium fragment, shear force is produced. Importantly, shear force promotes fractures that run in a different plane to compressive force. Then as the shockwave strikes the back end of the calcium fragment, a lot of it's reflected, and that generates what's called hoop stress or tensile stress that produces a different type of force on the calcium fragment. So if we just recap, IVL can be delivered over a standard wire, making it easy to use. It's a balloon tight technology, so it's, there's minimal learning curve. Selectively disrupts calcium. The shockwaves travel right through the vessel wall, so it's able to modify both superficial and deeper calcium. We only inflate it to 4 atmospheres, so it doesn't cause barotrauma. Its effect is not dependent on high hydrostatic force. There's no risk of embolization, which is important to know, and you can have a second wire to protect the side branch if you want. So this is the bit that I find interesting. Some people maybe not so much, but if you think about balloons, they produce compressive hydrostatic force, and that promotes fractures which just run parallel to the applied force, like this. Now, as we just mentioned, IVL produces compressive force, shear stress, tensile stress. Tensile stress, it promotes fractures that run perpendicular to the applied force. Shear stress promotes fractures that run perpendicular to tensile stress, and then we have the compressive force, which we've talked about before. So IVL, in difference to hydrostatic force only, promotes these crisscrossing of fractures to break up the calcium, and that's far more effective. And this has been consistently shown in preclinical work that we did with, for example, here I've got an example coming up. This is a cadaveric human SFA, on the left pre-IVL, micro CT so we can see the fractures, and then post-IVL you see this marbling, this cobblestoning, crisscross fracturing, which you can't see on OCT or IVUS. Remember, even with OCT, you can only see the fractures that are entirely aligned, axially aligned with the beam. So if you don't see fractures on OCT, it doesn't mean that the fractures are not there. I mean, it's encouraging when you see them to understand that the calcium is modified, but remember, it doesn't only show the fractures that are lined up to the beam. What else have we learned from the preclinical studies? This is another important thing, that we've shown consistently that IVL can modify the superficial and deeper calcium, and that this effect is independent of the calcium arc. I mean, I remember when we first got IVL, it was 2017 when I was working in Belfast. And when we did the rounds with IVL then, we were talking about how IVL is effective in a calcium arc 270 or more. I don't know if you remember all that. And we were there was these hypotheses going around that it was to do with reflection, that when there was concentric calcium, the wave was reflecting backwards and forwards, and that's why it was effective in concentric calcium. But actually, it doesn't make sense if you understand how shockwaves work. They don't care if there's calcium on the opposite side of the vessel. They pass through the vessel wall. If there's a big acoustic mismatch, they will disrupt that calcium. They will generate force. This idea about wave reflection from the opposite side, well, with the acoustic mismatch that you have between soft tissue and calcium, about 75% of the energy goes into the calcium. So you might get a reflection of about 25% of the energy going to the opposite side. So one wave might reflect, and that's down to 25%. So maybe you get some effect, but once it's reflected back one more time, you're down to 25% of 25%. So it's not so much down to reflection. And as I'll come on to now, we have data that's showing that's completely blown out of the water. It's effective of all different types of calcium morphology. So let's move on. Other things that we were initially worried about, is it going to produce thermal energy, or is it going to damage the surrounding soft tissue? Because if you produced a lot of disruption of the soft tissue, then we know that that does promote restenosis. From studies using OCT and IVUS, the more medial disruption, the more medial injury you got, there was a higher risk of restenosis. So we want to just modify the calcium. We want to modify the part of the lesion that's causing the problem, and we want to stay away from the rest of the soft tissues. So we've shown here that there's minimal rise in temperature with each cycle of 10 pulses, and it's well below the accepted threshold for tissue injury. And then we conducted a study looking at, can it damage or promote inflammation, fibrin, etc., injury in the soft tissues, comparing IVL with a balloon at 4 atmospheres and 180 pulses given, compared to a balloon just inflated to 4 atmospheres, and there's no difference. And that's consistent again with shockwaves. It only generate energy or forces when there's a big acoustic mismatch. When it's traveling from one soft tissue to the next, there's no forces generated. So that's important to me anyway. So now we have, so that's sort of the mechanism of action, what we found in preclinical studies. But of course, most important, what do we find in clinical studies? Does it translate to something positive to our patients? So there's the Disrupt CAD trials, which I'm sure you're familiar with. And that looked at, first of all, the safety and then increasingly the effectiveness of IVL in lesions, in patients that had angiographically severe calcium. And what I'm going to share with you is the pooled analysis from the OCT sub-studies, because I think it gives us much more information. It's more tangible. We can get more from it. So as I recall, I think, there was 248 patients where we got OCT runs before, during, and after. And we've looked at these now. This is just some of the baseline demographics, stressing that these were proper calcium lesions. They're angiographically severe, and the calcified length, as you see here, was approaching 43 millimeters. So, it's not a Mickey Mouse lesion. It was proper calcified lesions. Look at this as well. The calcium arc at the maximum calcium site was 270 degrees, and the calcium thickness was approaching 1 millimeter. And that's a lot. Once you get above 0.5 of a millimeter, that's causing a problem. Approaching 1, that's thick calcium. So it's a proper calcified lesions. So look at the outcomes. I think they're impressive. You got an MSA up from 2.1 to 6, and a mean stent area across the stented segment of 7.9. Remember, these are not left main. And perhaps most importantly, had a stent expansion at the maximum calcium site of 100%. And a mean stent expansion at the maximum calcium site, mean stent expansion throughout the lesion of over 100%. So acute mechanical result was extremely good in these with the use of IVL in these patients with angiographically severe long lesions. I found this really interesting when we went back and looked at the safety, because safety is always a concern with some of the technologies, particularly OPN and atherectomy devices. We looked at all 262 patients, and the incidence of any serious angiographic complication across these was 0. I mean, it's not to say that there isn't IVL will not be associated with a complication in the future. And this is 262, so it's a reasonable number, but it's not a huge number. But 0 incidents across those 262 patients, amazing. And the MACE rate at 30 days was around 4%. So very, very promising. What else did we do? Well, we thought, we've got all the data. Let's look and see if there's a difference according to whether, according to how many quadrants of calcium. As I said, they were angiographically determined whether they got into the study. They had to have angiographic severe, so supposed to have calcium on either side of the lumen visible on a single frame. But we know when we put imaging down, what we see on imaging can be often quite different from the angiogram. So these patients didn't all have concentric calcium. Some of them had eccentric, some of them had nodular. So we broke that down using the OCT, and we decided to look at by number of calcium quadrants. So less than 180, 180 to 270. So sort of eccentric versus more concentric. And what we found was that the MSA and the stent expansion at the maximum calcium site was consistent across all the different calcium quadrants. So we're seeing consistent outcomes irrespective of whether it was severe eccentric or whether it was concentric calcium. So that's a sort of real breakthrough. It goes against what we initially thought or hypothesized. But it is consistent with the mechanism of action. And then calcium nodules, which I still find the most challenging subset to deal with. We know they've got the worst outcomes. It's probably down a little bit to do with the nodule itself, can be difficult to deal with. But calcium nodules are associated with the most severe calcium, the greatest volume of calcium. They're often flanked either side by severe deeper lying calcium. And what we showed in these patients that had angiographically severe calcium, we stratified them as to whether there was a calcified nodule within that segment or no calcified nodule. And with IVL, they had consistent outcomes. Didn't matter whether they had a calcified nodule or no calcified nodule. They still had excellent MLA, MSA, stent area, stent expansion. Very promising. And I'll just recap. I'll just show you some data that was published just 2020 or 2021 with atherectomy and calcified nodules, because that was my go-to. Still use it a lot. But it was my go-to when there was a bulky calcified nodule. And with atherectomy, our outcomes in patients with a calcified nodule are significantly worse still. So there's still room to improve. I mean, these are outcomes at 1, 2, 3, 4 years. So it's slightly different. But it's very promising that with IVL, we're achieving consistent MSAs and stent expansion, whether you've got a calcified nodule or not. So we just summarize IVL. I mean, there's definite technological and operational advantages to IVL, which I've summarized here. You know, it's easy to use, it has differential effects, it can modify superficial and deeper lying calcium, not associated with distal embolization, and it's got a shorter learning curve. We've seen from the preclinical studies, mechanistic studies, that you get consistent, that it's produces crisscrossing fracturing of both superficial and deeper lying calcium. And now from these OCT analysis of the disrupt CAD studies, we've seen consistent stent outcomes and outcomes in the shorter term, irrespective of the calcium morphology. So it's a definite positive addition to our calcium modification armamentarium, and it's here to stay for sure. And I'd like to ask maybe the people on the panel a little fun question. If you only had one calcium modification tool to take forward for the rest of your career, you could have a cutting balloon, or you could have atherectomy, or you could have IVL, but you weren't allowed to have any other one, what would you take? I think I would probably take IVL now. I mean, I'd like them all. Of course, I would like them all. But it just covers such a wide spectrum of the calcium subtypes that we deal with. And I found it effective that it'd probably be that one. If I could have two, I'd have atherectomy and IVL. But if I could only have one, it'd probably be IVL. So that's just a brief rundown on MOA of IVL, my thoughts, etc. I'll hand back to Dr. Reddy, and I'd be interested to hear thoughts, questions, comments.
Thank you, Simon. It was a wonderful discussion on IVL. You brought out the finer nuances, especially the mechanism of action. It's definitely totally a different ballgame compared to the other balloons. And it's not the balloon. The IVL, the way it works is totally not only selective and specific for the calcium, but it's also a very safe expansion. A safe crackability of the lesion is what is very important in these calcific lesions. In fact, many a time, some will be tempted to use a non-compliant balloon, put it at very high pressures and crack the normal vessel, either ahead or upstream or downstream the block, and then the calcium doesn't give in. You will end up with a big mess of dissections, and then that will be the tragedy. So IVL definitely, as you say, I also agree with you. If I have to have only one equipment, it will be the IVL. The second one, of course, Rota. And this is IVL, I keep telling now that it is a mandatory equipment for all cath labs doing interventions. IVL, a covered stent, and a guide extension catheter. Without these three, you cannot think of doing the calcium cases. And these are all basic of calcium therapies. Wonderful. And one question from the audience is, in the recent TCT discussion about IVL probably being equivalent to the other balloons, NC balloons, what are your thoughts on that?
Being just the same.
Some discussions are there, of course. I won't accept that, because this is a specialty balloon, which is the real help, the one which gives the confidence to the cardiologist that he can crack any calcific lesion. But any thoughts on that?
What I would say is I use NC balloon still. Okay. Because, well, I'll tell you what I do is I use intracoronary imaging. We're lucky to be able to use that in most of our cases, but you can also integrate what you find on angiography, because angiography can give you a lot of information. If you do not see calcium, or if it's only mild on angiogram, what we've known from most of the studies are just based on angiographic analysis of the calcium, that it's unlikely that the calcium is going to lead to an unwanted stent expansion. So if I do see calcium on the angiogram and then I use imaging, if it's a thin plate of calcium or a short segment, I'll still try an NC balloon. I won't escalate the NC balloon or go to I won't go more than 18-20, and hopefully it yields, and I check in two planes. And if I've got symmetrical expansion around the wire, not just away from the wire, but around the wire, then I'm probably satisfied. But if on imaging I see, and combine that with the angiogram, if it's a thick plate, okay, irrespective of whether it's eccentric or concentric, or there's nodular, then there's no point sticking with an NC balloon, because as you just touched on there, you are in essence gambling. You're gambling that there's going to be enough expansion of the non-calcified quadrants to give you the result that you want. You may get a reasonable MSA, but you will always have some stent asymmetry, and you are risking a dissection or perforation. So if the angiogram or imaging tells me it's a thick plate of either eccentric or concentric, or it's a longer segment of more moderate calcium, I will go for IVL or atherectomy, depending on the type, for sure. So NC balloons are not out, of course, because we've got thinner plates of calcium and they're often okay. It's the more severe calcium. I personally believe you're gambling on a result with an NC balloon, and you're jeopardizing the longer term outcome.
Anantaraman, yes. What do you feel?
Hi, Simon. Nice to see you.
Yeah, you too.
Now, just going back in this sort of memory lane, 1999, 2000, in Blackpool, we were using routinely rotational atherectomies. And that time, we felt very, very happy. Then moving on to Cardiff in late 2000s, obviously, when laser came, we were even happier because you had a device where you can do the sort of calcium and thrombus away. Then when the IVL came, it became a luxury now. Now, as you were asking, if you wanted one tool in the cath lab, I think it's more of now it's become like image guided, everything image guided, and the selection is based on that. As you rightly pointed out, superficial thin balloons are fine. Otherwise, you modify as it is. Now, one of the things I want to ask is, in your practical experience, you have a 3.54 vessel and 80 to 90% lesion, and imaging catheter just passes through and you have got thick calcium. Now, you can make lumen, like a 2 millimeter balloon, and make lumen. Now, in that 3.44 vessel, what size IVL are you going to use, or what is your kind of practice?
Oh yeah, this is a great question. If I see very thick plates of calcium above 1 millimeter, and when it's sort of concentric, I think we have to recognize that no technology on their own is going to be sufficient in these larger vessels. So if it's more than 1 millimeter concentric, I would have a very low threshold for going up front with a combination therapy of atherectomy, because that's going to debulk, but it won't modify enough of the deeper calcium to get where we want to be. But that will debulk enough such that the IVL balloon will be effective. I understand that's a more costly way of doing it, but combination, we have to realize that all technologies, even IVL, has limitations. I've found that if the calcium thickness is above 1 to 1.2 millimeters, you got to think about combination therapy if you can do it. And it's always got to be atherectomy first to debulk, followed by IVL. It makes no sense to do it the other way around. Now, when it comes to choosing the size of the IVL balloon, this is a very good question. If there's the MLD is say 2 millimeters, and the reference diameter is 4 millimeters, I will choose a 3.5 millimeter balloon. I will not choose a 4.0 IVL balloon, just because we've got to accept that the IVL balloons are a bit more bulky. They're more bulky than an NC balloon to deliver. They're somewhere between an NC balloon and a Wolverine. And realistically, the calcium is not going to disappear. So you're not going to get malapposition as the calcium starts to disrupt and the vascular compliance is improved and the vessel starts to expand out. So I would choose a 3.5 balloon just to make sure that I'm going to be able to deliver it into the lesion and I haven't wasted one. But I wouldn't choose a smaller balloon than that, because potentially as the vascular compliance improves and the vessel starts to relax and expand out, you may result in some malapposition if you choose a much smaller balloon, and then your effectiveness of the IVL goes down because the energy transfer is wasted if there's not contact between the balloon and the vessel wall.
No, absolutely. I think that the important take-home message for people who are listening to this is, don't go by the exact vessel size, because you need to have contact with the IVL balloon with your vessel.
Yeah.
Same time, give you enough lesion modification and vessel modification. So do the inlet, but don't be driven by the vessel size to take the balloon size. And as you rightly pointed out, the thick calciums, you do need a combination of technologies, because one will not work. The other thing I wanted to ask is, I found it recently, is completely total pulses given in a left main calcified nodule. Rota was done, it didn't do anything. IVL was put, totally one balloon, complete all pulses given, nothing happened. Second balloon taken, halfway through the second balloon, only that calcium modified. So this we have seen in many cases. So the number of pulses becomes important in terms of modifying this very thick nodular calcium focused delivery. What is your thoughts?
100% agree. It's a dose-dependent effect. There's no doubt about that. I'm not sure, you may be aware, but the newer IVL balloons that are coming out allow us to deliver more pulses. So they're going to go up from 80 to 120. So that would have been right on the money for you there. So I agree. Definitely a dose dependency. If you have to get a feeling for things, which I'm sure you did in that case, that another IVL balloon is going to be effective, and it proved to be. So I did a case recently where we used 3, and I know that is quite a bit of money, but from the imaging experience, I knew it was going to be effective, and it proved that way. So with time, and we get a newer Shockwave give us products that give us more pulses, that'll obviate that issue. But I agree with what you said 100%. It's a dose-dependent thing. Sometimes you just need that more energy and that thicker, bulkier, particularly the larger vessels.
Sorry, obviously, I think we'll move on with the other case.
Thank you. I think, yes, I think time, we have to keep up with the time. And I think the next, we should welcome Dr. Vijay Bora, Senior Consultant Interventional Cardiologist from Command Hospital, Lucknow.
Ready, sir. In fact, Dr. Kaisar Khan sir actually requested. So we had requested Dr. Bora to accommodate Dr. Kaisar. So, sir, if you can kindly call Dr. Kaisar for
Dr. Kaisar Nasrullah Khan from Bangladesh. I think, Dr. Kaisar, welcome, and we will be happy to see your presentation on the managing the calcified lesion, a never-ending challenge. I think it will be an interesting starting case presentation. Please.
Yeah, thank
Dr.
you, sir. Can I have my slide share? I think the previous slide should be taken off.
Yes.
Simon, can you please,
if you can kindly unshare.
take off your slide.
Simon, if you can kindly unshare.
Of course. Sorry, no problem.
Yeah, thank you, sir.
Okay. Just need.
Kaisar is from United Hospital, Dhaka, and experienced interventional cardiologist.
Thank you so much for your kind introduction. Assalamu alaikum and very good evening to all. Really learned a lot from your discussion and Simon's lecture. So I've got a very simple case to share with you in Dhaka, Bangladesh, in my hospital. We just started IVL in Bangladesh. I think not many cases has been done. of course, economic is the issue. But what I find in my practice, maybe I've done very few cases, but it's a very bulky device to take inside the lesion. But what I felt, so that's the only challenge. What I think with IVL, sometimes if the lesion is tight, to get the balloon into the lesion is sometimes get difficult. So at the time you have to do rota and then take your balloon there. That's the only challenge. Anyway, I have nothing to disclose. So this is already shared by Simon. So I will skip this slide because he described it very well. So I don't think it needs to be said. But one slide I should focus that this IVL can be now done in every part of our body, and from starting from coronary to renal to femoral, and even doing TAVI, you can deal with the iliacs if it's heavily calcified. And what we've all learned from that we have to size appropriately, 40, 60, 50 dilution, and then do the pulses with 4 atmosphere, then take it to 6 atmosphere. Very basic things. Now, my case. A 76-year-old fragile lady got admitted with chest pain for 2 days. She was hypertensive bronchial asthma, well, hypokinesia with normal EF, but drop leaked. And she had a history of previous PCI to LAD and SARC. This is her EKG. You can see dynamic EKG changes. And this was her first angiogram as planned. The first look was not pleasing. You can see obvious calcium in the cine. So you can see there are osteoproximal ISR in LAD and also 95% osteoproximal with the proximal instant ISR in SARC. So we can see prominence of calcium in the both arteries here, both without dye and with dye. RCS seemed quite normal, nothing significant. So my plan, the problem with 74-year-old fragile lady with non-STMI, with ongoing chest pain, DVT with osteoproximal ISR in LAD and SARC, heavy calcification. So PCA cabbage, both options were discussed with the patient. Patient family opted for PCA, maybe she was old. Now, challenge is PCA is osteal involvement of both LAD and SARC, especially SARC is sure. So I decided to take help from imaging. Heavy calcification, I kept cutting balloon, IVL rota in my armamentarium. Left main involvement strategy, though left main looks normal, but if it is osteal involvement, then we need to also deal with left main. So take a XB San French guiding catheter through radial route. But I tried to take the IVUS, but unfortunately IVUS failed to cross the Boston IVUS, maybe due to calcium or maybe the curve. So I took a 2.5 balloon first because here IVL is very costly. It's not reimbursed in my country. So I tried to do it with balloon, but it didn't open up in the osteal sac and proximal ISR. So heavy calcium, what now? So again, cutting balloon, OPM balloon, IVL, rota. The problem, this is the MI setting, lots of thrombus. So I was, and curved vessel, and ISR. So I was skeptical about rota because it might produce more embolism, and curved vessels sometimes cause perforation. And it's ISR. So considering all the factors, we opted to go for IVL, punch the lesion rather than drill. So we took the IVL and 2.5, I think, balloon, and with 4 atmosphere give pulses of 10 waves. And post IVL, the ostium sac was further dilated by using 3x12 balloon, but I thought that if calcium had cracked, now it will give way to the NC balloon. Now we could pass the IVUS in the sac, and we could see the proximal part was still not optimally dilated. And then I took 3.5, a safe cut balloon, and then I took a short balloon, 3.5A, to specially give pressure on that point where it's not opening up well, and took some close magnified views to see. And then we can see, we can again take the IVUS, and now I can see the calcium rim is cracked in the both sides. So if you can get two cracks in the opposite side, now I'm quite confident that I can oppose my stent well with the valve. So later, SARC bed was prepared. Then I went for LED lesion, opted for IVUS to see the ostial LED. And again, I can see there is a long arc of calcium in the LED as well. And ostium seem a bit stenosed. So as there are significant stenosis, I took the IVL balloon there. And then after doing, I think 10 or 20 pulses, I again took 2.5 into 12 NC balloon to optimally dilate the thing. And after pre-dilation, I took IVUS again to see the LED. And again, it showed dissection flaps 2 or 3 sides, so which gave me quite a confidence that I can take my stand now. So now it came to the decision of the technique we would prefer. Left main, no significant involvement, but we had both ostial involvement of the LED and SARC, and it's a left codominant system. So that's why we opted for decay crash. So it is quite first taking the stand in the SARC, keeping one strut in the left main, put the stand, then took the balloon, keeping the balloon in the left main to LED, crushed the first stand, rewired, first kissing, and then took the stand in the left main to LED. Then the second crushing the stand of the SARC with the left main to LED stand. Then again rewired, pot, and then second kiss. And after the second kiss, I did repot. So post-stentic IVUS was done in LED and SARC, which showed good stentic apposition. And again, I did post-stent IVUS in the SARC as well. And MLA of left main was also satisfactory. It was 10. So you can see the MLA of LED, and SARC ostium was 5, and left main also 10 point something. So final angiogram showed both LED and SARC were well revascularized. So my challenge for this case was, it was a MI setting. I was very much cautious about the thrombus containing lesion. Second, the curved vessel, and that's why I was not comfortable with rota. And there's ISR as well. So IVL gave me a bit comfort while doing this case. It's an old lady. So my take-home message is, every interventionist should train and use IVL, because easy to use, no extra guide wire like Viper or Rota wire, and very short learning curve. In Rota Viper, you need time to learn. Third is, we should keep it in the centers for cheap, who do cheap rotatripsy. We can do Rota and lithotripsy as well. Laser tripsy, center for CTO, lower risk than Rota in subintimal space. Sometimes while doing the CTO, you have to go to subintimal space and then connect with the true lumen. So at that time, doing Rota in the subintimal space, if you dilate it, the CTO portion, then it's very risky to perforate. I will give lower risk, and also TAVI center for easy passage of the calcified iliacs. So number 4 is, I will especially take edge over conventional atherectomy device in concentric calcified lesion, medial calcification, curved vessel, acute MI setting, ISR, and under expanded stents. Thank you all. Thank you.
Thank you, Dr. Kaiser Khan. And you have shown how easy it was to do a complex case like this with IVL. Imagine you had to struggle without an IVL in this setting, and would have been a real horror tale. What do you say, Simon?
Oh, great case. Yeah, it really showed. I particularly like the cop. It's exactly how I would have done it, really. To be honest with you, create some space, get the imaging down. You tried a balloon, realized it was underexpanded. Used the IVL, and then on top of that, in the circumflex, there wasn't enough compliance still. So then, was it a cutting balloon? In the LED, it was sufficient. And I think the acute stent result, you saw concentric. I know people don't believe that much, or there isn't that much evidence to support stent symmetry as a major predictor of outcomes. Certainly with a stent symmetry index of above 0.7, I don't think there's that much data to support it. But if you go below 0.5, there is some evidence. So what I saw from the IVIS imaging there was concentric stent expansion and good MSAs. So I think it was a great case and a great result. And I also like the comments about the different areas that you can use IVL in. I mean, it's it's taking over. You've got it in TAVI for peripheral vessels, or you just got it in peripheral vessels for peripheral vessel angioplasty, followed by IVL first. And then in CTO, I do use it in CTO within the subintima. Not so much within the subintima, because usually you don't need that much lesion modification in there unless you've got a lot of medial calcification. But I've often found a problem when you come from the intima up into the subintima, and the reason you've done that is to go past a big calcified segment. There's a lot of calcium in there, and you can often get some stent under expansion where you exit from intima or plaque into the subintima, and that's a problem. And you used to rota that, but now you can IVL it, and same at the distal transition point. So yeah, I like to talk and agree with all the comments about the areas where we can use it. And also, of course, it's off label, but in ISR, sometimes it's the thing that gets you out of trouble, particularly the sort of STEMIs in the middle of the night, and you don't fully maybe spend as much time evaluating the angiogram, and you get the stent, and then you're left with a real napkin ring of under expansion, and it can be extremely effective in that because you're very limited at that point. So thanks for the talk, enjoyed it a lot.
Thank
Thank
you.
you.
Hasan, who's Dr. Vijay Bora is
Yes, sir. Yes.
I think we should welcome Dr. Vijay, senior consultant from Command Hospital, Lucknow, who will be talking on the best practices while using IVL in complex cases.
Good evening, sir. My screen is shared now?
Not
Dr.
yet.
Bora, I think we are not able to see your screen till now, sir.
Okay.
Yeah, now it's visible, sir. You can put it on the PowerPoint and then you can go ahead, sir.
Is it
Fine.
visible? Is it visible now?
Yes.
Good evening, everyone. And at the outset, I thank everyone, Translumina, Shockwave, for giving me this opportunity to present my case here in front of this August gathering. So the topic given to me is best practices while using IVL in complex cases. So calcific coronaries have been seen since the mankind, as was given by this Horus study, which showed that Egyptian mummies also, around 30 to 32% cases showed calcific coronaries when the atherosclerosis study was done. So since that time, we have been dealing with calcific coronaries, and in 1988, Dr. David Oth was the first person to give us something like a rotational atherectomy. And then Dr. Todd Britton was co-founder of the Shockwave to have given us a blessing in the form of intravascular lithoplasty. So I'll try to delineate the best practices in the form of a case presentation. My patient is a 78-year-old gentleman, a diabetic hypertensive, who presented with class 3 angina and episodes of intermittent wrist angina. His ECG showed ST depression in the inferior leads, and echocardiography shows some regional wall motion abnormality pertaining to the RCA territory with the LV function of around 50%. He had normal valves, his hematological and biochemical profile was normal. Starting with the angiography in the AP caudal view, as we can see, calcification in the left LAD, which is diffuse, circumflex proximal chronic total occlusion. And if in the third frame, if we can see the diffuse stenosis of the LAD from proximal to almost distal, crossing the diagonal to, and a retrogradely filling RCA and evidence of calcium in the distal RCA. The right coronary angiogram showed calcification in the prox to mid RCA, which was tortuous, heavily calcific, and a distal RCA, a calcific lesion along with a chronic total occlusion. The PLV also looked affected at the crux. And as we in the same angiogram, we can see in the LAD territory, the calcification which can be seen without the contrast. So as a fact, we start with a imaging first kind of this thing in our lab. We first image the coronaries prior to doing any intervention in a calcific lesion so that we can delineate our strategy of taking care of this calcium. So as we can see, there is calcification in the intimal and the medial planes, which is here can be seen from 3 o'clock to almost 9 o'clock position. Then calcification, which is almost making a 180 degree to 270 degree R. Some calcification in the intima media, which is deep also. This is between the thin and the thick plates, not more than 1 mm at places. The pre-PCI OCT pullback, the distal luminal area was 3.11. The tightest area had a luminal area of 1.73 millimeter square with a 180 degree arc. There were areas of 270 degree arcs as well. So as given by Fujino et al., we have a OCT based calcium volume index score in which we take care of the maximum calcium, the amount, the degree, the arc of calcium which is there, the maximum calcium thickness of more than 500 microns or less than 500 microns, the length of the calcium in the coronaries, giving a total score of 0 to 4. And it has a direct correlation with the stent expansion. A score more than 4 gives more chances of stent under expansion. So what option do we have? So still we go in for rotational atherectomy. We have got intravascular lithotripsy as nowadays, and cutting balloons, scoring balloons. We do not have the luxury of orbital atherectomy or a excimer laser at our center as of now, and we do not also have a CTVS backup. So this is a slide which I've taken from the from a state-of-the-art article from the JACC intervention, and which showed that if we can predilate and we do intravascular imaging, see if there is not a deep calcium, we can go in for a non-compliant balloon, high pressure balloons, cutting or scoring balloons, get optimal balloon expansion, and then do our stenting. However, if we are not able to do that, take a IVL in deep calcium, straight away take a IVL balloon. And if there's, though there is a calcium arch which is there, but not a deep calcium, then we go ahead with a rotational and orbital atherectomy. For lesions which are not balloon crossable, we use a upfront rotational or an orbital atherectomy, make way for the intravascular lithoplasty balloon, and then do a PCI and get us do a plaque modification and do a stenting. As we all know, calcium impacts us a lot, as was told by Dr. Simon also, that it's still a trap. Dr. Reddy also mentioned that it is a trap when we started, but we have a lot of things in our armamentarium, so things have become better now. So it leads to suboptimal stent expansion, sometimes ISR, stent thrombosis, failure to deliver the device, increased number of complication, increased procedural times. So initially I thought that the patient had a double CTO or PDS, or distal RCA CTO or circumflex proximal CTO, significant lesions in the LAD. So I thought sending him for a CABG may be a safer bet, but since the gentleman was 78-year-old, wanted a angioplasty, opted for an angioplasty. So we went ahead with a rotational atherectomy for the LAD. I thought I'll secure the LAD first and then move on to the RCA. We took a rota 1.75 burr at 160,000 RPM and modified the lesion. This is the post-rota burn. We can see some amount of dissection which was present, some amount of thrombosis also, and then after in the post-rota pullback, we saw that there was evidence of some thrombus, some dissection which was there, and minimal areas of some the calcium fracture were also visible. So we had a luminal gain of from 1.5 to 3.18 millimeter square. We then took a Scoreflex non-compliant balloon, a scoring balloon of 3 into 15 mm, and then we took a 1:1 optimization of the plaque, modified the plaque. The scoring balloon inflated well. There was no dog boning, and thereafter we took a stent. We deployed the stent, and then this was the final result. We took a post-OCT, post-stenting OCT also, which showed a well-opposed, well-expanded stent with a minimum stent area of 5.2 and a good expansion of around 98%. But the challenge was the RCA. LAD, I thought, was to secure so that I do not have any untoward event while I'm doing for the RCA. So I staged the RCA for after a week. And so now I thought, what should be my strategy? Because I do not have a place to put in a rotawire. I do not know where to put the rotawire as of now. And intravascular lithoplasty would have helped, but I initially wired and then took a balloon, and the balloon didn't go. So now I was stuck that I cannot use a IVL. So I initially wired, took a 1:10 balloon, distally inflated it, then proximally at the maximum calcification, I inflated it and thought there was some amount of, there was some flow which was restored in the distal RCA. So then I took the rotational atherectomy, took a 1.75 mm burr and tried to plaque modify. Before that, I tried to putting in a OCT to do the imaging first, but however, the OCT didn't go. Even the IVL also didn't go. So then I thought I should take in a rotational atherectomy. After doing a rota, as you can see in the prox to mid RCA, it is all a mess. There's a lot of dissection which is there. Distal RCA, in the distal embolization is also there. You hardly can see the PD filling. And then we took the OCT pullback. As we could put the catheter now. And as we can see, this is a distal landing zone, which looks okay. While as we come proximal, we see areas of calcifications, which are almost 270 degrees, as we can see from here. And this is the calcium, which is a deep calcium, almost from 12 o'clock to 7 o'clock, and calcium. And as we can see, there are gutters also which are being made by this rota. As we can see, the OCT catheter, the rota would have gone there, and there are gutters which have been made, and a lot of deep calcium which can be seen in these images. At this place in the co-registration, we can see that there is some amount of calcium fracture also with the help of the rota. Then we took the size of the cornea was at mid RCA was around 3.5. We took a 1:1 correlation of the IVL and took a 3.5 into 12 mm intravascular lithoplasty balloon, gave almost the total pulses in the whole RCA from mid to proximal RCA at the places which had the maximum calcification. This is the post IVL OCT pullback, and as we can see, there are at the 9 o'clock position, there are multiple fractures. Now you can see at the 12 o'clock, fractures in there, fractures here at the 2 o'clock, 3 o'clock, 6 o'clock, and multiple fractures which have been there, which means that the plaque has been really well modified. And at here also at the 9 o'clock position, there was good plaque modification. And here we can see that the interface between the vessel wall and the calcium, where the OCT catheter is there is at this interface of calcium, the vessel wall and the calcium, there is a fracture which can be seen, which was also seen after rotational atherectomy, but this has definitely become a deeper fracture now and has given an additive effect to this plaque modification. So there was a gain in the luminal area. There were multiple fractures which were there, which showed that the plaque has been adequately modified. However, the story did not end here. I had problem putting in the distal stent, so I have to take a buddy wire, add a guide extension. As Dr. Reddy said, that we should have a guide extension, a rota, and a IVL with us, and a covered stent. So those things came out to be very handy. Took a guide extension, delivered the distal stent, then delivered the proximal stent, and this was the final result. This was the OCT pullback after the results. There is some evidence of tissue prolapse from 3 o'clock to 9 o'clock position. And then, as we can see, that the stent is very well expanded. The minimal stent area was 5.83 millimeters square, and the stent expansion was around 96%, which for this kind of lesion was adequate. So this was the final result for the LAD and the right coronary artery. There was no edge dissections. So a lot has been spoken about IVL and eccentric lesion, as Dr. Simon had already shown us that with or without even a concentric calcification or eccentric calcification, the stent expansion and the minimal stent area has been seen to not been significantly different. It has been the same. Similar is with the OCT findings in the studies which have shown that calcific nodules, with or without nodules, the stent expansion remains the same. The stent area also remains the same. There's not much of a significant difference. Sometimes we can't see any fractures. The DISUP CAD3 showed that calcium fraction can be seen only in around 68% cases. So the hypothesis given is that there may be some out-of-plane fractures, there can be microfractures, and beyond the spatial resolution of this present-day intravascular imaging. The pre-IVL and post-IVL micro-CT scans which were done, this was a TCT 2021, which was presented by Dr. Ziad Ali, that the OCT sub-studies showed when they have done a micro-CT, they showed that post-IVL also there is microfractures which are there, which modify the plaque, change the compliance of the vessel wall, and help in the good stent expansion and the apposition. So best practices for me is therapy in calcific lesion has to be tailor-made for the patient and the coronaries. Intravascular imaging is a must and should be first in case you can do it. If you are not able to do it, then obviously we do dilate the lesion or say do a rotational atherectomy and make space for the imaging catheter. Therapies for calcific lesions, they complement each other to achieve good luminal area. Now, advent of non-compliant balloons, high pressure balloons help with rotational atherectomy, intravascular lithoplasty balloons. So they give adequate stent expansion, and they should be taken as a complementary thing to each other. And as from the DISRUPT CAD series of studies, IVL is a very safe and effective tool for optimal results in heavily calcific lesions. Thank you.
Thank you, Jay. The wonderful case, especially the right coronary, the usual challenging case. If you get such a case as a primary or a non-STEMI, and then you're doing in the middle of the night without IVL, I think it will make our life very, very hard. In fact, I recommend that IVL should be a part and parcel of every lab. not just the specialized labs like Kaiser was alluding to, because in the era of primary PCI, we don't know who is going to be having such lesions, and we should have it in each and every lab. I see we have a wonderful panel of cardiologists, accomplished cardiologists here. Dr. Sanjeev Agarwal from Chennai, Bala Vignesh, Basavaraj, Dr. Pinto, Karthikeyan is there, Giridharan. Is Dr. Sanjeev there? Sanjeev, I saw you. I think you're not there, I think. Okay, any comments from panelists and co-chairs?
There's exceptionally good cases, both cases. I think it shows how some kind of people adapted now the algorithmic approach of imaging, modification, and also combining the technologies as required for each patient rather than just going with the fixed idea. I think your case is exceptionally good, both lady and right. The way you have adapted, the way you have modified the lesion, and these results would not have been possible before the IVL era. I don't think we would have had this kind of stent expansion and excellent results.
Definitely.
Now we can compare it to CAPG. I don't think we need to worry about. Yes.
I agree with the comments. Can I ask two questions? The first is when you rotated the LED, did the patient have any hemodynamic compromise or were they stable?
He went into a bit of hypotension because the RCA was also not helping us. The circumflex proximal was cut off. So, but I thought that saving the LAD first and then doing that complex PCI of RCA was would have been better.
Oh, I agree. I would have probably done the same way. I'm just interested because it's definitely a downside of rota. It has to be considered. Yes. You know, that patient has severe IVL, it's a problem. And that's one potential advantage of IVL over atherectomy in these kind of cases.
Definitely.
The second question I had was, now that you've been using IVL, and we saw an excellent example there, has your practice changed? You got IVL. I remember distinctly when we got IVL, we used it so much, and then maybe forgot about the other technologies, and now I've gone back. Or have you been more of a slow adopter and sticking with what you had before, and then just gently bringing in IVL? What's your experience been?
Initially, sir, definitely when we started with rota, because of the learning curve. So we thought IVL came as a boon to people who did not have to struggle with that rota that much. So initially, the change is definitely there. And if you have IVL on the shelf versus you want to do a rota, you will like to go into a safer option for the patient. But definitely rotational atherectomy or orbital atherectomy for that matter has not lost its importance as of now. So it all depends upon the coronaries. Like in this RCA, nothing could go. Even the OCT catheter won't pass. So at that point of time, I thought that rotational a rota for making a place, do some plaque modification would help me perform that case. Without IVL, I would have achieved that much amount of plaque modification, but definitely without rota, nothing would have gone inside. So that ways, but definitely we are moving over to more of intravascular lithoplasty in view of the safer options, it being a safer option for the patient. So that ways, and the now as you had also shown that eccentric lesions, calcific nodules, they all can be modified using intravascular lithoplasty. So we are changing a bit, but rotational atherectomy, etc., also still have a very important role in our day-to-day practice.
Yeah, I think that's an important point, isn't it? It's that this is not as saying IVL is to be used exclusive. You know, as people are saying, it's absolutely the right word. It's complementary. IVL is complementary. It's not exclusivity. And I think that was a great example. Used the imaging. I definitely agree that I needed atherectomy followed by IVL.
Dr. Sanjeev Agarwal, I think you're back. We can have your comments on that. I think again we have launched that net there. I think we'll thank you, Vijay. A nice, wonderful presentation. We'll go to Dr. Praveen Srikumar from Master Medicity.
Thank you, sir. Thank you.
He's going to talk on complex made simpler with IVL. A very apt statement.
Am I audible?
Yes.
Yeah, thanks. My screen is visible,
Yes,
right?
yes.
Yeah, okay, thanks. We started our IVL program in our city in Kochi about 2 years ago. So we did our first case. This was the first case that we did. We thought that over the past 2 years, we've been having a very good experience with IVL. It is very complementary to Rota. Our only concern so far has been with left main proximal left main lesions, where we had to use Rota, and the IVL had a problem because we had to wait for some time. We cannot allow so much of coronary ischemic time. So that was our only problem with IVL that we had. So far, it has been good. And we also felt that if even for left main lesions, suppose the pulses are rapid and there are more pulses available. Like in this case, we had the only balloon that was available in India at that time. So in this case that I'm going to show, actually suppose we had a more pulses like 12, it would have been better. Just a minute, I think I'm unable to forward my slide. Shall I stop and?
Sir, you can stop and then do it, sir. It will be better.
Yeah, I think I'll stop share and redo.
And then again do it, sir. Maybe some technical glitches would be there.
I think I have an open PowerPoint. Now it's good. So this is an 80-year-old male, diabetic hypertensive with recent onset effort angina, and coronary was done outside for the TBD, so they came up for angioplasty, and ECG was sinus rhythm. He had significant effort angina. He was 80-year-old and he was actually working in the field because now he stopped his work at home because of his angina. So that was the indication for, and his LB was normal. He was normal. This was on the left side. This was okay. My codec is not playing. This was a lesion that we had. There was an LAD lesion, circumflex lesion, and a ramus which was big, and that was also this ramus looks small, but actually if you see the towards end, you can see that it's actually a big vessel. We did the initial balloon with this IVS catheter was not going in, so we had to do some initial ballooning. So we did some initial balloon with a pre-dilatation balloon and did an IVS on 3 vessels. So this was the ramus. Can see the arc of calcium all throughout, almost 270-degree arc of calcium. So we dilated after this. My codec is not playing, sorry. So this was the ramus, and the initial post-dilatation we had to do with an AccuForce balloon, and that NC balloon we could do it, but the vessel was not fully open. And okay, and this was the IVL balloon. This was a 3.5 IVL balloon which passed after the NC balloon pre-dilatation. And 3x12 Shockwave balloon was used in the ramus, and it would go up to the mid ramus. So ramus after all was a big vessel because you can see the dilatation. Unfortunately, the video is not there. That's right. IVL to LAD and LCX was also done. We used 3 sets of pulses in ramus, 2 sets of pulses in LAD, and 2 sets of pulses in LCX. So we had used 7 pulses of 8 so far. So, and this was the LAD LCX bifurcation. We did a kilo, and after kilo stenting, then we had after that LAD was standard with a 3x38 science expedition, and LCX circumflex was standard with 3.5 38 science expedition, followed by simultaneous kissing post dilatation. And then we went ahead with the ramus, wired the ramus, kept a balloon there, and after SKS, wired the ramus, and through that did a reverse T just after the kilo bifurcation, and ended up stenting the ramus with a long stent of 3 into 38 stent in the ramus also. 2.5 into 38 in the science expression in the ramus, and post dilated to 2.75 balloon with the poster. And after that, there was thrombus in ramus, and we wanted to do an IVS later also post. So because there was a thrombus, we did a thrombus suction with a thrombus aspiration catheter, and immediately, and then followed by again, we did an IVS after this. Ramus, this was a ramus bifurcation post dilatation. So post dilatation, this was a LAD IVS, which showed a good expansion and good MLD. And after that, we had a LCX thrombus, and that was also aspirated. And even though our heparin, we had kept a heparin ACT of 300, thrombus was forming. Probably was the problem was with our IVS catheter. It was in vivo. It was collecting thrombus. So we did a thrombus aspiration, and finally went for a triple balloon simultaneous post dilatation, which showed a good result. Actually, the codec is not playing. Unfortunately, I'm unable to play that. We got a full expansion and good results finally. This case, we never used a rota, even though we had a backup rota with us. We never used a rota throughout for this. We could do the case. Left main did not have a calcium, but a lady ramus, which was a big vessel, had good calcium. We could pass a balloon with the help of an NC balloon pre-dilatation, and then pass the balloon somehow. Somehow, in this case, the balloon passed. And we used 7 pulses in total, which was just required for this. Probably if it was 12 pulses, we could have gone ahead that did more in LAD, more in mid LAD and LCX. So that was, unfortunately, the codec was not playing. Otherwise, I would have done that.
Praveen, you might just go out of the slideshow and click that image. It will run. Just go out of the slideshow.
Okay. Okay. Stop sharing. Out of the image here.
Escape.
No, just
and then just click that. Yeah, no, still not working.
No, I think it's a codec issue, codec incompatibility issue. So I wanted to show the video because we had this was the first case, one of the first case, but we had many cases. After that, we started using IVL very extensively with us.
Yeah, the left main calcium, you were raising that point that whether the patient can tolerate ischemia for this 10 pulse. I think it's extremely rare for someone not to be able to tolerate. And so we can shorten it down to a few pulses, I think. In left main, especially post bypass, left mains, protected left mains going into circ or LAD. Tense calciums, this is a really useful technology. Nothing else will work there.
Yeah, definitely. Well, for left main, somehow major debulking probably rota helps along with then do an IVL, probably that helps. So for the gross debulking, IVL, I am not sure whether they do a very gross debulking, but we have good results. We had good results with left mains also, where we did with IABP. So with an IABP use, the ischemic time probably they tolerate well. So most cases with left main, when we take up with an IABP or any cardiac support, probably this is easy.
Yes, Anantharaman and Simon, yes.
The other thing we do with the left main is just 5 pulses at a time. You give 5 pulses, give a break, let the artery breathe, then give another 5 pulses. So that way you just give a prolonged ischemia, and that helps.
Okay, but once the series of pulses given, it just suppose only 6, 1, 2, 3, 4, 5, 6 is done and you stop it. That is counted as one series pulse, or
no, it will still be able to deliver the rest of 4 pulses. So you give 5, stop, you will still be able to do the rest of 5 before this clock resets. Yeah. So you will not lose out the pulses.
Yeah. But that's a good point as well. But there's no point giving 8 pulses, because the next time you can only give 2. So just give 5 and 5.
Yeah. Thank you.
Even though
I think
a good example of one of the areas that we can use IVL, and we could see even without the expansion.
Yeah, if not for IVL, I don't think we would have done this case.
Yeah, it's a very nice.
Whatever would have damaged the ramus.
Yeah, exactly.
Shall we? Thank you, Praveen.
Yeah.
I think we have time. I think should we go to Dr. Deepa Krishnamurthy from Sakra Cardiac Institute on Shockwave sound calcium strategy.
Good evening, everybody.
Yes, sir. Deepak, yes. Need to share your slides.
Yeah, man. Hope my slide is visible.
Yes, sir. Yeah.
Sorry. So, good evening, everybody. This is a case of calcific vessel with an acute MI and decompensated heart failure. The patient is an 82-year-old lady who is a known case of calcific triple vessel disease with a CTO in the RCA. The angiogram was done in January 2021. Counseling was done about options of surgery versus multivessel angioplasty. We offered to at least do the LAD and the circumflex, but at that point they were not really keen about complex procedures. They said they would like to continue on medical management, and if she's stable, just do with that. But she presented around last year, around October 2021. That is after 10 months of the angiogram with acute pulmonary edema. She was intubated in the emergency, stabilized. The ECG showed an evolved anterwall MI, ejection fraction of 35%, normal kidney functions. The patient was stabilized for 24 hours and the risks were discussed, and she was taken up for PCI with IVL. So this was her angiogram from January 2021. Here you can see a CTO in the RCA, quite a bit of calcium visible there. This is an injection in the left ileocaudal. There is an ostial circumflex disease. So this was the LAD, which was calcific, and after the diagonal there was a tight lesion in the LAD. The diagonal also was fairly big, also had a tight lesion. So we wired the LAD with a filter. We also took an additional cyan blue for extra support. So initially we had to go with a 1.25 into 5 balloon, followed by a 1.5 balloon, followed by a 2.0 balloon to make some space, because the cutting balloon couldn't be gotten across. The IVL balloon, of course, wouldn't go into it. It was very tight and calcific. So after dilatation with 1.25, 1.5, 2, and then a 2.5 Wolverine cutting balloon, we were able to get the 2.515 shockwave balloon across the LAD lesion. Series of shockwaves were delivered, and we were able to make good progress with the shockwave balloon. We were able to deliver a 2.75 stent into the distal vessel, and then it was overlapped with one more stent, which was the 322. The first one was a 275/26, and the second one was a 322 Resolute Onyx, both of them. And post-dilated with 2.7512 followed by a 312 non-compliant balloon. We did not go too aggressive with the post-dilatations because the angiographic result looked good, and it was a calcific vessel in an elderly lady who was already in pulmonary edema and hypotension on inotropes and ventilator. We did not do a bifurcation because we thought establishing the LAD flow would be good enough for her, and This is the final result with a good TIMI3 flow in the LED with well expanded stent in proximal to distal LED, two overlapping stents. So she was extubated the next morning. She became stable, shifted to the room on the 4th day from CCU, discharged on the 7th day with an ejection fraction of 40%, doing well. She had an episode of paroxysmal atrial fibrillation with stroke in the MCA territory after 3 months. So she has been put on anticoagulation. She's more or less wheelchair bound, but no further chest pain, no further admissions for pulmonary edema or acute MI. So we have kept her on medical management. There is no plan to do any revascularization on the CTO of the RCA or the ostial circumflex in view of her overall general condition. This is a case to show that even in the sickest of patients, even in the presence of heart failure, patient ventilated with LVF, with IVL, we can get good results. And at least, if not achieving total revascularization, we can salvage the patient, get them out of the ventilator, get them out of hospital, and discharge them. Because sometimes with some of these sick patients, even getting them out of the ICU, it becomes a big challenge. So IVL helped in this case to do that effectively. Thank you.
You're on mute, Dr. Reddy. You're on mute, sir. You're on mute.
I'm sorry. Yeah. See, a nice presentation, Deepak Krishnamurthy. And I would ask Anantaraman, Simon, and also all my panelists are there. I think Dr. Sanjeev Agarwal is in as well. Are there any tricks you use to deliver this device to use to cross the lesion with the IVL balloon? Any specific, I think each of us would have developed some small tricks up our sleeves. What do you share, I think? That will be useful for the newcomers.
For us, it's easier because we have got the laser, so we can run the laser, use a two balloon, and then take a guide extension and put it. But I think for centers who don't have laser, there's no harm. Just prepare it with two and use a guide extension as freely as possible. As you were saying right at the beginning, starting these cases without a guide extension is a no-no. I think delivering with the guide extension support, once you deliver it, sometimes you don't need to deliver it completely in the lesion. Even if you deliver it just proximal to the lesion, the first couple of sort of 10-20 pulses, then it makes its way through. Then you just deliver it into the lesion, and that's how I've been doing. Simon?
Same thoughts. With a guide extension catheter, it's going to deliver most of the time. As I said in my talk, I feel it sits between an NC balloon, not quite as deliverable as an NC balloon, but it's more deliverable than a Wolverine balloon of the same size. So, that's an issue. But with a guide extension catheter and sustained force, it will usually deliver. And as was just mentioned, if you nose some of it in and give a few of the 10 pulses, then it will go. If you do get it to deliver, always, as we normally know, start distal to proximal. Because another, because an unwrapped.
Yes.
What a challenge is if you think, I'm going to do the circ lesion, 40 pulses in that, and then I'm going to do 40 pulses in the LED. Now delivering the unwrapped balloon down the LED, that's going to be an issue. So bear that in mind as well. If the LED is more important, do that first. Do you agree?
Yes, I think.
Go for your vessel of choice, which you want to save first, rather than the lesion which looks kind of difficult or less difficult. Because that day, if you save LED, go for it. After that, it becomes very difficult to deliver the used IVL balloon.
Yeah. Another thing I do is I don't know. I mean, the advice that was given to go from 4 atmospheres to deliver it, and then go up to 6 atmospheres. Speaking to Ziad, etc., that was just a sort of somebody came up with it for no real reason. That's what they say. Because obviously in these lesions, we're going to take an NC balloon down afterwards. and we're going to take that up and make sure we've got compliance. It's rare that you'll take the IVL and then after that go straight with stent. So personally, I've lost a couple of balloons by going up to 6, or maybe the registrar trainee is a bit enthusiastic, doesn't go 6, goes 8. So now I never take it up beyond 4. I go 4, deliver it, and then down. There's just no advantage, and if you lose an IVL balloon after 20 pulses, it ruptures or something. It is frustrating. So I go 4 pulses, down, wait, etc.
Interesting observation, because I always used to do that 6-1 for one reason, silly reason. The reason is we are so impatient in the lab, and the moment the pulses are delivered, there is a tendency for the sister to deflate the balloon, and we don't want to do that till the green light comes back. So the one way is go to a 6, wait, and then of course the green will come and then deflate. Otherwise, balloon ruptures are more because of very fast early deflation as well.
Yeah. I'm very impatient as well.
So what about IVL balloon ruptures? I have had one, and I thought it was the early deflation by the sister which caused that. Any thoughts on that?
I mean, obviously you don't get the barotrauma with it that you do when you've got a balloon up to 20, 22, 24 atmospheres. It's just a sign, I think, that you're dealing with nodular calcium. It's often nodular calcium. So it's a warning that you've got nodular calcium. We all, have our little anecdotes, etc., and it shapes our practice so much. I've had a few that have ruptured at 6 or 8, or teared anyway, and then I've lost it. So I only go to 4. Whether that translates into reduction of it, I just stick with that because I don't see an advantage to going up to 6 because I'm coming back with my NC balloon to much higher afterwards. Anybody else got any thoughts?
Yes.
The newer one doesn't cause that much rupture. The older version, there were a couple of ruptures, but the newer ones, I've not had any recently. So
that's very true. I've seen nothing in the last 12 months. What about has the panel ever encountered capture, and what do you make of it? And does it worry you? Do you do anything different? Capture when you get shock topics, when you start pacing the heart.
Yeah, when you see it in the screen, when it's running on top of your RNT like a phenomenon, when you see that pulses running, sometimes you do worry whether you're going to get it. And there are reports, there are case reports of figuring, but I have not had any arrhythmias or anything because of this pulses as such. Apart from seeing it on the screen, I have not had anything personally.
Yeah, I think it's important to be aware of it. If you start using the device, you'll see capture. Basically, the IVL, the energy generated will trigger capture through electromechanical coupling, and it'll produce a pace beat, an ectopic. And it's a pace beat or an ectopic because you see that associated drop in systolic blood pressure because you bypassed the atrial kick, etc. And at the beginning, we were worried whether it could cause this R on T. There was one case report. There's been one case report, but I haven't seen any others. And there was another issue as to whether it could cause inappropriate suppression of people who are pacemaker dependent. If they didn't have an underlying rhythm, but it was enough that the pacing device itself thought that there was a beat and then suppressed pacing even when the beat wasn't captured. But we did a whole pile of patients on pacemaker and did live recording, and there's the bandwidth filter on the pacemakers is advanced enough that it just filters it out. You can see it filters out that electrical mechanical signal. So if you don't get capture of the heart producing a heartbeat, it will not cause suppression of the pacemaker device. So it's an interesting phenomenon. It's really heart rate dependent. You really don't see heart rate below set, if the heart rate's much above 70, 75 for obvious reasons. I find it's much more frequent in the proximal to mid RCA, any proximal to mid vessel. You very rarely get it in the more aorto-osteal left main, doesn't cause a problem. And it's an interesting thing. I've never had a patient come to harm, as you said yourself.
Ehsan, do you have any more presentations, or we can carry on with discussions?
Sir, no, we don't have any more presentations, sir.
That's
I think
wonderful.
all the speakers spoke on the topic. Sir, actually, I just wanted to share one thing, sir. In fact, to this luminary panel, in fact, we have Dr. Wilson, Dr. Anand Raman, sir, Dr. Reddy, sir, and Dr. Bohra, sir, still there, and Dr. Sanjeev Agarwal, and Dr. Vasav Raj Uttagi, sir. In fact, sir, I was just trying to, there was one question that what is, do you find Shockwave and IVL same? And Dr. Wilson answered it very lucidly. At the same time, I was just thinking that why this question was being asked. So I was doing a double click to find out into the Google that is there something material of that nature. So what I found to my surprise, that there's something called exit calc study, which was recently presented in the recent TCT in the late breaking trial. And I was, in fact, I thought that on the hindsight, is that person who was asking this question is just trying to ask in that relationship. So this was a study which was a 40 patient where one group was given IVL and the other group was given normal NC balloon, and the parameters which were taken were the stent expansion index. What was found that both of them had equal results, but the NC group achieved a similar kind of a stent expansion index with a lot of dissection, and at the same time they had also used a scoring balloon, and this was not a great number to study, and this was not core lab adjudicated. So therefore this had its own set of flaws, but perhaps someone on the hindsight was trying to understand. Sir, any thoughts if you have, sir, you can, because this is all of you, because we still have the limitations of understanding science than way you understand it and you interpret it is always far more prudent rather than we doing it, sir. So over to this group before we close for this wonderful evening which we had.
I got a couple of thoughts about the study design for this, because we thought about doing a study. And if I was to design a study to compare the effectiveness of IVL, it would have to be after, you'd have to incorporate imaging, and it would most likely have to be after NC balloon. So probably take an NC balloon. We thought about this so much. Probably use an NC balloon and limit the atmospheres you could to 16 to 18 atmospheres, go up to maximum rated balloon pressure. And then if you got inadequate lesion preparation after that, randomize them then to either NC cutting or OPN and or rota versus a shockwave arm. So they're quite difficult to construct the study, but I suspect that study wasn't that. It was just IVL versus NC. And as we know, we're not saying that IVL is going to replace NC. We're saying it's complementary. So it would really depend. You'd have to dig down into what was the calcium morphology, because if it was largely thinner plates, etc., or, a calcium quadrant of only one, etc., it's so much to disentangle in these. So it's interesting. I think actually what it does is confirm that IVL is not the be all and end all. It's complementary, and we have to select then the lesions where it's going to be most beneficial.
See, for those who are interested in making sure that the cost economics are important and you want to use IVL only for the really needed cases, what I usually teach is first look at balloon crackability. Sometimes say NC balloon 18, 22, it won't crack. So that is it. You have to use IVL. There's no alternative there. That is the safest way of doing it. The second is the safe crackability. You might be tempted that maybe if I go to use an open NC and go to 35 or 40, I might crack. But that might be a little bit, it has its own risks. If you don't have the IVL, I would do that. But otherwise, their IVL I would use. So non-crackability with the NC balloon at good pressures, or unsafe crackability zone you are entering with very, very ultra high pressure balloons, I think that would be it. But preemptively using an IVL based on an imaging and all that, of course, that is a luxury. That is where probably these trials, when you say NC also might work, that might be an area of contention. But if finances and the cost issues are not an issue, probably we'll be using much more cases than what are the real deep necessary cases.
I agree with you. I think I've not gone into the details of the one you mentioned that presentation. I need to see that. But what is more important is this trial and error phenomena we had quite a lot before IVL came. We used to put in a balloon, we used to dilate it. Sort of 8 out of 10 times you get away with it. The 2 out of 10 you have a perforation, you have a very prolonged, because you will be repeatedly using many balloons. You'll start with the 2.5 NC, 3 NC, 4 NC. Your procedure time is 2 hours, 3 hours. Contrast volume is quite high. All those has been taken out. As soon as you see a more than moderate amount of calcium in the imaging, you just put an IVL, modify the lesion, your procedure is finished within 30 minutes. Now, what you were mentioning that simple NC balloon versus IVL, I have not seen into that, the procedure times, the contrast volumes, all the other associated things. But once you have one bad experience with an NC balloon rupture and the patient going hemodynamic compromise, then you will rethink about going back to your IVL again and modifying and doing it in the way which we are doing now. Cost is the issue, but if cost is taken out of the equation, as YVC said, safety-wise, that's the best approach. You do the image, you identify the calcium severity, you go with the best calcium modification, you come out with a good result.
Another important point here for the audience, in case you are putting a stent in not so well prepared lesion, calcific lesion, the bed is not yet prepared, the carpetability is not there, you put up a stent, and then you try to go in for a non-compliant balloon post-dilatation, especially if there's an eccentric calcific nodule, that is where stent causes coronary rupture. So prepare these lesions very well. The best bet is use the IVL in these cases well before, prepare the lesion, then go for it. And don't bank on putting a stent and then I will do a post-dilatation. That is a very risky recipe.
Oh, Dr. A, such a good point. I mean, your options to modify the calcium after the stent are in are just severely limited. And I think, although IVL and or laser can bail you out on occasion, I think their effectiveness is still less. So it's so important to be absolutely certain that the vessel is compliant enough to get the full stent expansion before you deliver the stent. I practice similar to you, actually. I often, where it's not clearly very bulky, thick, long segments of calcium, I'll take an NC balloon to 16, 18 atmospheres. And then just exactly what you said, if after that it doesn't fully go up, then imaging to understand what the best calcium modification tool is, because as Dr. Anna Mathura just said, it will save you time. It will be more efficient and probably more cost effective, rather than having a lot of lithotripsy or rotor regret at the end of the case, where you've got NC cutting, scoring all around the houses, and you've got a big dissection and you've lost 2 liters of sweat, So that's such an important learning point. It will translate to a more efficient, more effective, more reproducible result for both you and the patient.
Yes.
I was going to ask the panel something else, if they've ever used it to modify the proximal cap of a CTO. For example, the nightmare CTO, that's a flush ambiguous or a flush LED CTO, and you've got a big ramus or a circ sitting next to it, or similar, down the mid circ and there's an OM1 branch next to it. Has anybody used it to modify outside in? Put the IVL balloon in the ramus branch and then modify the cap by putting 40, 50 pulses, because you do not cause any disruption of the ramus, for example, because you're only ballooning going to 4 atmospheres. I don't advocate that as first practice, but if the cap's unpenetrable and you've got nothing left, and it can be to do a base and go a scratch and go around the cap means you're going left main, and you've got a risk then at that point after stenting of losing the side branches. Is effective. I'm telling you, it's effective. You put it in 40 pulses, modify the cap, and then you'll be surprised how much your sort of penetration wire can then go across. So it's just another little thing that
interesting. Yeah.
What can it not do?
It's
I'm wondering when
yes. Yeah, not like that, but yes, yeah.
I'm wondering when the first IVL of a calcified aortic valve is going to happen.
It's coming up. The IVL.
Anantraman sir, your views on this, sir? This on CTO. this is quite interesting.
Yeah.
Sir, there is a registry. I think there was a registry, Crunch registry also run, I believe, on that. Sir, any views on yours or Dr. Vora, sir?
And I've definitely used it in. I've used it quite a bit more in CTO. I often find in CTO PCI that, particularly towards the beginning when you're still finding your feet, that once you've crossed and you secured the distal vessel, you kind of forget about the calcium, or you forget about getting an optimal stent result. And that's actually much more important in a CTO, because CTOs tend to be longer lesions. And they've got independent predictors that are going to affect stent durability. So therefore, any calcium that's encountered is even more important that you disrupt that calcium and get an optimal stent deployment, because you're probably going to be putting a longer segment of stent in. So yeah, I've started to be conscious more, think about calcium more in CTOs once I've crossed, use the imaging to decide it. And it definitely gives you a feeling of comfort to use IVL when the wire often tracks intimal, subintimal. We're not always truly subintimal, not always truly intimal. There's often segments that are in and out. And using IVL in those scenarios, you just don't have any concerns compared to, for example, atherectomy. So yeah, IVL definitely effective, and use it quite a bit in CTO, not just to modify the cap, but to modify the body of the lesion and try and get the best result.
Yes.
Regarding the crunch registry, Mr. Ehsan, we had also a few cases where we landed up with an expanded stent, and which we used IVL. And to our pleasant surprise, IVL bailed us out. As Dr. Reddy said, that it is difficult to be in a situation where you have an underexpanded stent and the mess is there, rather than prepare the bed well and then put in a stent. So IVL has bailed out at around 3-4 times when we landed up with an underexpanded stent, though it's not one of the indication as of now. But yes, it is effective. As Dr. Simon also said, that in our armamentarium, we have limited tools for an under expanded stents, especially when you landed within the STEMI in the middle of the night. At that point of time, the IVL is helpful. Definitely, you have nowhere to go except for the IVL for that under expanded stent. So we've used in 3-4 cases of under expanded stent, and we also did OCT post this thing, and we found a good MSA and a good stent expansion post that. So IVL in the future, this may be one of the indication for an under expanded stent for the usage of IVL.
It's one of those things that routinely draws a gasp in the cath lab, just from not just the operators but the staff when you put a balloon up and it's completely dog boned, But it's another great feeling as well when you use a balloon or lithotripsy and it just 10 pulses pops open. It is a good feeling.
Yes, there is a sigh of relief after that. You can send the home and you not lose on your sleep after that. So it's a sigh of relief when you send in with a very well expanded stent rather than a patient going with an under expanded stent.
Have you used lithotripsy much in eccentric and nodular calcium? Is that something that you do, or did you just reserve it for concentric?
Yes, we as a protocol do imaging in all calcific lesions, and we have been using IVL in eccentric and nodular calcium. The incidence of nodular calcium in our patients slightly lesser, but yes, eccentric calcium we have used and found to be effective. We have demonstrated calcium fractures despite it being an eccentric lesion. So things may change from here. Even all those studies also which have showed that eccentric lesions also, it would have a greater role from now on.
I think so. In eccentric and nodular lesions, if you compare the alternative technologies which you can use, like a rotor orbital, which we don't have, or an open NC balloon, or there probably this IVL is going to be the safest way. I think that that is the one which we should be relying upon in such scenarios.
Absolutely, sir. Absolutely.
Yeah, safety is unquestionable. Yeah, I think calcified nodules are still a challenge, but we've learned so much from the OCT sub-studies of the Disrupt trials about calcified nodules, about how we've been thinking about it more. They're a really interesting subset, tend to form, if you get them more at their infancy, they often have a sort of lipid bed underneath them because they tend to form from lipid-rich plaque within an area of torsion. And those two components, the lipid-rich plaque means they've got less of the proteoglycan collagen to allow the calcium to coalesce into sheets combined with torsion. So at the beginning, they tend to have this lipid pool underneath with a fragment on the top, but you can't see that on imaging. And I don't know whether it's your experience. I've been looking out for it now more. You often get a calcified nodule that if you just use an NC balloon, it just disappears, and we've been tracking that more, and that's probably about a third to a quarter. It's because there's still this lipid-rich pool underneath, and the calcified nodule just goes into this pool, separates out. But in about 3/4, it's not the case. And you can't predict on imaging which ones will behave like that. Probably the only ones you can predict are the ones that won't. When you combine the angiogram and you see just that it's a huge thick plate underlying that, that's not going to happen. That's more an iceberg. But these ones, it'd be so interesting to be able to pick them out. And it's my practice now, actually, unless I see this huge thick plate underpinning it, then I'll take an NC balloon actually now, but only go to like 12, 14 atmospheres. And if it goes, then great. You're one of those jackpot ones where it's the 25%, where there's just a lipid pool underneath and it's gone. And if it doesn't behave like that, then I'll often go to IVL unless there's long, thick plates of calcium that are obviously going to favor debulking with atherectomy. And the reason why I think IVL is so effective in these patients is the surrounding calcium. It's deeper down and it tends to be thicker. And I think that's why IVL, for the mechanisms we talked about today, is the most effective modality in those types of patterns of calcium. I don't know if anybody got any sort of thoughts about that or experiences on that.
You brought out the subtle difference between the nodular calcium and the eruptive calcific nodule. The words sound similar. The English meaning might sound overlapping, but the ones which look like a clot, roundish, and some trainees might mistake it for a clot, it is a nodular calcium. Those are the ones which are real challenge, and there, if the IVL balloon can cross, I think that should be the choice. The eruptive calcific nodule is the one you alluded to. It just looks like some calcific, nice one. We put a NC balloon and just it gives in very easily. And usually they come with ACS. They do well even without IVL. That is a ECN. But these nodular calciums, which sit there in the RCA like a blob, like a nodule, that is going to be a big tough thing. Of all the modalities available, none of them is going to give a great result because the calcium muck is going to be there. Expansion might not be full, post-stent imaging as well. But of the technologies available, I think the best bet is IVL. If you can't get the IVL balloon there, of course, we have to use a bit of rota, then the IVL balloon, and then do for whatever best expansion. It is only with IVL finally.
Yeah. They're definitely a challenging subset, really interesting subset, the calcified nodules, or the nodular calcium. It's a confusing nomenclature.
Yes.
We need to.
Thank you. Thank you. Sir, I think everything good comes to an end. And sir, I think we were clockwise correct. In fact, thanks to this moderation of Dr. Reddy and chairing the session, Dr. Anant Raman sir. It's always a pleasure having you and adding a lot of value from all of you, sir. And Dr. Reddy has nicely alluded to all the points. And thanks, Dr. Simon, for joining in from overseas and giving us some basic concepts of understanding of Shockwave IVL, which is so important. And I think you were someone who would, right from the inception of this technology, you were involved, and I think you brought out, so in a very pristine way, you brought the actions, and I think, I'm sure it would be beneficial to about 500 to 700 people who had joined for this evening, Friday evening. And thanks, Dr. Bora sir, for bringing some of the case studies. So overall, thanks to the audience who have been joining in. Sir, I would only request that as as this product evolves, and as we get to know more and more and the experience comes in, the only thing is that the best bet is to give the benefit of this wonderful therapy to more and more patients. We look forward to see that more and more patients, because we are all, at the end of the day, all the stakeholders sitting here with you and the clinicians, a wonderful clinician sitting here, is all for the patient. We being a patient-centric company, we always look forward at how do we support these patients. Thank you very much. And as we sign off from Shockwave Translumina, it's a pleasure having all of you, sir, once again.
Thank you all. Good night and have a beautiful weekend.
Thanks, everyone.